Can PowerPoint on the screen? Thank you. To the organizers of this conference and the funds and Shupyk Healthcare University for hosting us. I'm so happy to be here today. And today we will look at disorders related to abuse of psychoactive substances during war and the and its consequences. So these are my personal opinions. They reflect the opinions of my university, and I have no financial conflicts. So we have certain goals. We have to look into impact of the war on these disorders. Like it's either alcohol consumption or other chemical substances consumption. So this data about these disorders in our times during the invasion, we will look into the best practices for treatment of such disorders. And we must understand these needs will not end with the victory. So, so PBA, alcohol, IDPs, internally displaced persons, opioids, and general substances. So as we know, stress or physical or psychological, it manifests in the body. There could be like hormonal changes and factors in the brain, and it gives you the propensity for certain behaviors. You eat more, you sleep less, you feel anxious, and one of the consequences is people under stress. They have this propensity to use psychoactive substances, or if they use them before, they use more of them. So there are many reasons for this. So there is also types of stress and how long you are under stress, and also individual qualities like your genotype and the past of that person. So maybe that person had previous traumas. Like in Vietnam, there were 20 men in jungles, and there were difficult events of their life, but one or two of them had PTSD only. So, so the same stress in the various people has various consequences. So also the social integration of these people, people who are more socially integrated, who are more connected, they have goals in life, they have the propensity is not so strong to use substances. So the war, all the things that protect us, it kind of disrupts, and things that damage us, so war is the biggest stress you can come across. So what are the published data about the stress, about the life, about with using substances? So there is not very few data that you can really trust, because it's difficult to collect this data during war. Because in wartime, all the attention, all the resources are aimed at survival and saving life and at finishing the war. So people who go to the front lines, to the battlefield, they just want to save their lives. Who is going to ask them about substances? So when the war is over, they will say, okay, forget about everything and move on. So all the all the wars that we had in previous centuries, also we have very little data about the psychiatric substances usage. But there are certain reviews, there is certain data. So like the Middle East conflicts, there's certain information, and also about IDPs. So from that data, we know that in general, the more stress there is experienced during conflict, the more there is the risk of acute usage of substances. You know, the veterans in USA, there were two campaigns, Iraq and Afghanistan. And there was a list of people, and they sent and there is more percentage had problems with alcohol, which is not surprising at all. And it was also found that the men, not women, who were younger and had no close relations, like they were not married, they didn't have a partner, and they had more combat experience, they had more tendency to use substances. So, one more important thing, those who had depression or PTSD, they had more percent of them used alcohol. So it's a synergy between those disorders and substance abuse. So they are correlated. It's like a vicious circle, that we have to break.
Dobra.
Okay, fine. So, what do we know? We know that the war started back in 2014, and during the first year of war, there were attacks, there were injuries, there were explosions. Unfortunately, back then, there were not much formal lists, but civilian people, many civilian people were internally displaced, and they also showed higher instance of alcohol use disorder. They, it depended on the severity of anxiety. It's also correlated with the severity of anxiety. So, we also know that the number of appointments with psychiatrists during back then increased. And now let's return to our current time. The war is ongoing, and there are limited data about current situation, but we still do have some data. So when the war started in occupied territory, access to opioid use disorder treatment decreased. But we know that the consumption rates increase. So it's not easy, but there is a big problem with substance use among civilians. Now, unfortunately, we don't have high quality public data about these issues due to various reasons, but there are some NGOs, non-governmental organizations, who study this area and publish report. There is a global initiative against organized crime, and there is a monography published in March, and it reflects current situation based on limited data. So there are no formal data issued by government, but still. So the survey was done. 1,000 combatants serving in the front line were surveyed. And according to the respondents, alcohol is most widely used psychoactive substance. No surprise, and high percentage of combatants at least once a month used a high quantity of strong alcohol, strong spirits. Now let's take a look at two bottom scales. Pink on the left shows substances used at least once a month. And the top second after alcohol is a cannabis. And next go amphetamines, which cause arousal and increase focus and vigilance. In United States, this opioids. In United States, they used to reduce they illegally. Then so-called best salts, which are the worst. They often not seen on urine tests, and this is the umbrella name. Bath salts These are various designer drugs where someone changes one molecule and no one has no idea about regarding effects, and then go other substances. So these are substances used daily. And we see that certain percent of combatants used cannabis daily in higher doses. Out of them, 7% took pergabalin and some percent used amphetamines daily. Luckily, not much opioid use. Okay, good. So here we have a paradox. Because there are efficient the armed forces roost. I'm not a serviceman, but armed forces have zero tolerance to drugs, including even methadone. And people who use these substances may be held accountable because it may result in various consequences. And according to the statute, if someone is killed in combat and remnants of prohibited substances, traces of prohibited substances are discovered in the body, the benefits for family may be cancelled. And at least in papers, the military servicemen do regular blood tests for various substances. Last year, new strategy on Veterans Affairs was released, but it did not mention substances and substance abuse. So literally it means that almost allowed. Once again, according to NGO reports, why it happens? There is a need to fulfill military recruitment goals, and background checks upon joining military are very superficial. So people with addictive substance use disorders can be still drafted. Therefore, we suspect that a percentage of former or current substance users in the army might have increased significantly during last years. There are also problems during combat actions. Commanders have limited resources, and let's mention there is a military serviceman who adequately fulfills duties but uses substances. The combatants may not be interested in referring such servicemen to studies. Military personnel have no initiative to self-report, because it may result in consequences. Therefore, we don't know a real rate of monthly and daily consumption. It's an important issue, but based on what I read, both alcohol and other substances can be purchased by various groups of military servicemen rather easily. So why do military personnel use substances? It's based on results of surveys. They use amphetamines to maintain vigilance and energy, because it's about survival. Another very important thing is self-medication. They experience anxiety, depression, loneliness, PTSD, sleep disorders, and they want short-term tension release, even despite long-term harm, but it provides immediate relief. The war waged in Ukraine is unique because of drone warfare, and there are some assumptions that combatants who sit in trenches and cannot even leave a trench for many days because of drone hazard experience higher stress than normally. Because when we are under stress, we feel an urge to move, fight or freeze. Body has an urge to move, but they have to sit in trenches and just endure it. So there is assumption that this is a novel stress for us and it may be more intense. So it can be one potential contributing factor. There is also boredom. Sometimes people feel bored when nothing happens, and physical pain, where often the addiction develops as a result of injuries. So I've just mentioned these factors, and they're especially relevant in Ukraine. Back before the war, the country had higher alcohol and opioid consumption use, and during early stage of war, a significant percentage of military servicemen used it at least once in the past. Sometimes use of substance mobilization is a punishment for substance use, which also contributes to higher percentage of users in the army ranks. And there's also convergence with other diseases, with traumatic TBI, with PTSD, and they flare together. So sometimes soldiers have to wait for rotations and evacuations for a long time due to limited resources and forces. So a person who's feeling bad has no chance to recover, resulting in a feeling of helplessness and high mortality. So this war is special. It definitely causes more intense distress with weather. So how to overcome it? First of all, we have to admit this problem. This problem is in US Army. This problem is in Ukraine Army. We have to accept it. Then we need to improve data collection. Maybe government has this data, but at least we don't have access to them. Then we need to design a kind of patient route for military servicemen, because if you use substances but you want to continue military career, you can receive treatment while in military and return back to your commander and continue deployment. And we need to separate punishment from treatment to avoid stigmatization. And those who are dismissed from service need to continue in treatment and they need to be followed up. Now, challenges related to treatment. Treatment is especially complicated because these disorders are chronic, they often relapse, and they are surrounded by stigma, internal stigmatization and external stigmatization. Therefore, treatment must be multimodal and long-term. Some of them, some and many treatment modalities have inadequate efficiency. So for alcohol, we have some treatment standards. Behavioral approaches like motivation, CBT, positive reinforcement, 12-step program. These are very important things. We can also add pharmacological therapy. Now we use naltrexone intraorally or intramuscular, and it reduces the drive. Sometimes it's not efficient to address abstinence, but it reduces heavy drinking, binges, and number of hours after influence. We also use pyromed or paragabapentin, but these are useful in combination of therapy. You cannot just give him pills and send him away from your office. So these are just supportive strategies. Unfortunately, we have very limited time.
Будемо дуже вдячні.
So I will skip a few slides. It's important to also treat comorbidities such as PTSD, TBI, pain, somatic pain, chronic pain, because they contribute to substance use. And in order to deal with it, we need to remember that it's moral, economic, and demographic imperative. These are mostly young people, working age people, and they got corrupted by the substances, while country needs labor force, human resources. These people need to somehow be reintegrated into society. So I'm just about to finish, and after the victory, these patients will continue, and they can be and must be treated.
Дякуємо вам за час.
Thank you.